Hello, everyone, and welcome to an SNIS webinar sponsored by Penumbra. We're here today to talk about the mechanical thrombectomy experience during the COVID-19 crisis and what sort of impact we're seeing from COVID on both our patients and on the people taking care of the patients. I'm joined today by Dr. Alejandro Spiota from the Medical University of South Carolina and Dr. Robert Stark from the University of Miami. And for the purposes of this discussion, we're going to start with a multi-center study led by Dr. Spiota. And so I'm going to let him take it away and present some of the findings.
Perfect. Thanks so much, Adam and Bobby. So very much excited to present some of the recent findings. This is hot off the press, just recently analyzed from a multi-center effort and collaboration, really describing the effect of the COVID pandemic on both our patients, as Adam mentioned, as well as the providers. And this, I should mention, although you're hearing me present the data, all the credit goes to our collaborators. This is the first joint effort between STAR and the Energy Group, which is the Endovascular Neurosurgery Research Group, STAR being the Stroke, Thrombectomy, and Aneurysm Registry, which has been growing over the last several years and now has over 8,000 patients enrolled. And of course, the Energy Group, led by Andy Ringer out of Mayfield, also a group that's been around for many, many years and very productive. So this is a collaborative effort, and really all the thanks goes to all our collaborators who worked to get the data in a near real-time fashion for us. So a bit of the background on the two areas that we investigated. Number one, given the risk of exposure, as we know, to providers during COVID, as well as the frequently unknown COVID status of our patients presenting with LVO, and the acuity of intervention required, many societies and centers adopted modified protocols during the pandemic. For example, all patients presumed to be COVID-19 positive until proven otherwise. Some centers lowering thresholds for pre-procedure intubation. So that's one area we'll look at. The other was, given the small size and specialized training our endovascular units, and really being irreplaceable, how did our groups fare? Quarantine or actual illness from COVID, were we able to maintain our services and maintain the stroke services that our patients so critically require? So really the purpose was twofold, like I mentioned. Really, how did our patients fare, and how did us and our providers fare? So the first purpose was to describe the mechanical thrombectomy experience during the COVID pandemic across diverse demographical regions, looking at both quote-unquote hot zones versus cool zones, rural versus urban settings, looking at time metrics and outcomes. Could we identify any potential impacts of protocol modifications on our patient outcomes during this time? And then lastly, with regards to how our providers did, we want to evaluate the effect of the pandemic on the provider workforce. Were centers able to maintain their services? How often were they on diversion? How many providers actually were out on quarantine or actually sick with COVID itself? So the first purpose of describing the mechanical thrombectomy experience during the COVID pandemic. This we launched in February. It was a prospective multi-center international observational study. As I mentioned, it was the first collaboration between the STAR initiative and the Energy collaboration. We drew data from 3 continents and 5 different countries. Among the US, we had many states represented. A total of 28 sites contributed data. And here again, many thanks to our phenomenal collaborators. You'll see Adam Arthur's and Bobby Stark's institutions were also collaborators, and really had a big contributions from across the country and around the globe. And again, just thanking our many collaborators. Couldn't have done it without all of them. We divided for the purposes of calling a cool zone versus a hot zone. We used the criteria of whether there were more or less than 500 cases per 100,000. And I'll just mention that, for example, New York City currently is at 1,800. So centers were either very much below this or very much above it. So changing this threshold, which is somewhat arbitrary, would not have changed the results. So if you were greater than 500 centers, the hospital, we looked at that county it resided in, and these were considered high COVID burden counties, HCCs. If it was less than 500, we were considering them low COVID burden counties. Of the 28 centers, 5 were in high burden areas and 23 were in low burden areas. This is just a map illustration showing the distribution of the sites. You can see the red or high burden COVID regions, Seattle, Chicago, and the New York area and Philadelphia, and the remainder being relatively cool areas. So we looked at 458 patients. Again, 28 sites, North America, South America, and Europe. These are consecutively treated LVO patients for a 2-month period. For sites that saw the surge earlier, it was February, March. For most of the sites that saw it later, it was March and April. Overall, 13 or 2.8% of the patients that were treated with mechanical thrombectomy for LVO during this time period were ultimately confirmed to be positive for COVID-19. And there were 242 of those 458 patients that were tested. You can see in the high COVID regions, 17.3% of those that were tested were positive. In the low COVID regions, 2% were positive. Now, a word about this. In the next slide, I'll show you overall COVID positive tests. Different centers use different protocols. Some centers tested only those that were under suspicion. Some did not test initially, and as the period advanced to more recent times, they were testing more frequently. So a different way to look at it is that the patients who were actually confirmed to be COVID positive, and keep in mind that some of the centers use different criteria for testing, was in the high COVID regions 8.6% compared to 1.1% in the low COVID regions. And looking at patient characteristics among those that were confirmed to be COVID positive versus those that were neither confirmed or were not tested, you can see overall those that were confirmed COVID-19 positive were younger. They had a higher NIH stroke scale and actually a shorter door to reperfusion time, or a trend 0.06. Looked at practice patterns by COVID burden location, so high versus low. Here in the red is the high COVID burden data. You can see demographic characteristics are similar with the exception of IVTPA being more frequently administered in the low COVID regions. Intubation rates, surprisingly, actually higher, almost twofold higher in the low COVID burden regions. Door to groin times, not surprisingly, longer also in the low COVID burden regions with a trend of 0.05. We then looked at general anesthesia versus conscious sedations. Overall, 241 of the patients, 52% of the patients underwent planned procedure intubation. I'll mention the majority of the sites were not intubate all thrombectomy shops. They were intubate as needed. So that did mark a significant deviation for the normal protocols. Of those undergoing monitored anesthesia care, only 2 patients, 0.9%, actually required emergent conversion to GA intraprocedurally, the feared aerosol generating component to the thrombectomy. Again, here in a table looking at those undergoing planned pre-procedure general anesthesia versus moderate constant sedation. So those under general anesthesia were actually younger, had higher rates of IVTPA pre-procedurally, higher rates of or incidence of posterior circulation LVO, and longer door to groin times, longer procedure times, and longer door to reperfusion times, and a lower likelihood of having good outcome on modified Rankin 0 to 2 at 90 days. So just to summarize, compared to monitored anesthesia care, patients undergoing GA, again a pre-procedure planned GA, they were younger, more likely to have received IVTPA. However, longer door to groin times, longer procedure times, longer overall door to reperfusion times, and less likely to have a good outcome. On multivariate analysis, intubation status was associated with a higher probability of in-hospital mortality, relative risk of 1.8, and a lower probability of functional independence, good outcome, with a relative risk of 0.53. So conclusion of the first part of this study, which is really how did the patients do? We found this prospective multicenter international study compared to non-COVID patients, COVID-19 confirmed patients were younger, had a higher NIH admission, although they had similar outcomes and recanalization success. We found a low number of COVID-19 infections, about 1%, among patients with LVO and undergoing mechanical thrombectomy in low COVID burden counties. Of the 23 sites, 19 saw 0 COVID positive patients undergoing mechanical thrombectomy during a 2-month period. We also found a very low rate, 0.9%, of unplanned emergency interprocedural intubation. And lastly, patients who were intubated prior to mechanical thrombectomy were more likely to have in-hospital mortality and less likely to be functionally independent at discharge. The second stage was, again, seeing how the providers, how did we do, how did our techs do, and our nurses do. And this is, again, a STAR and Energy collaborative effort. We had slightly more sites, so here we got data. We received data from 34 centers across some other international sites. We evaluated just under 600 providers, 251 nurses, 228 techs, and 113 physicians during that time period. And this is a snapshot showing areas that are in the very high prevalence regions: Chicago, Philadelphia, New York metropolitan area, Atlanta, Seattle, versus the cool areas. The white column is the white part of the histogram is the percentage of providers that were available the whole time, versus the green is providers that were quarantined either from symptoms that could potentially be COVID or from a COVID exposure. And those red areas are actually providers that actually had a COVID confirmed illness, so were infected with COVID-19. And looking at that data slightly differently, you can see 16 centers were low COVID burden, 18 were high COVID burden. The emergency operations cancellation elective cases, as you mentioned, were similar in the two areas, about 14 days. Implementation was 14 days after the first confirmed case in that country or that state. You can see providers that are self-quarantining. In low COVID areas, physicians 4% versus 8%, significantly higher in the high COVID regions. Nurses and technologists quarantining at a much higher rate, 39 to 51%, and similar across low and high COVID burden regions. And then lastly, very importantly, those that were actually COVID-19 positive. So much lower rates, and this is an important finding: 0% of physicians, nurses, or techs in low COVID regions were found to be COVID-19 positive throughout the period, compared to 25% of those, not overall, of those who had quarantined physicians, and 19 and 12% of nurses and techs, respectively, who had quarantined were found to be COVID-19 positive. So this illustration shows in a pictorial, if you look at it, these are 100% of interventionalists. A few percentage were self-quarantining in low COVID regions, but none were red in the low COVID. Nurses, technicians, none were COVID-19 versus some low but not insignificant rates of COVID-19 positive infections in the high COVID regions. So in conclusion, we found that in all low COVID burden regions, there were no healthcare providers infections, physicians, techs, and nurses during this time period. So that's the data from the multi-center effort. Again, I really appreciate the opportunity to be able to present this, and I really look forward to the discussion that will follow now.
Well, thanks, Alex. Interesting stuff. Bobby, any comments jump to mind looking at those data?
First of all, really great efforts by all the STAR and ERG collaborators. I mean, tremendous amount of work went into all of this, and thanks, specifically to the MUSC team for leading up all the analysis. I guess one of the key elements is how many centers were making drastic changes in their protocols during the COVID period. I think a lot of centers had a major shift in their protocol going forward to screen for COVID patients. And then on top of that, you had another set of centers that may have had a big shift in how they were actually doing the thrombectomy. So whether they were using anesthesia or non-anesthesia. I don't know, Alex, if you had any thoughts about those things as well.
Yeah, absolutely. I think you're right on, and that's a critical part. So for the STAR sites, the majority of sites were not an intubation for all, approach. So the intubation did, as you mentioned, was a significant deviation for what they ordinarily do and what they're ordinarily very fast and efficient at doing. So we looked at the STAR data from several years back, the 8,000 thrombectomies that we have, and it was about just under a 10% intubation rate. And in this data, it was well over 52%. So definitely a higher rate of intubation overall. The majority of the sites, I believe it was 75% or even 80% of the sites were not intubate, a priori. I know Miami was and Emory. So it really did constitute a major change. And like you mentioned, beyond the intubation, beyond the time that the intubation eats up, there's also the local protocols. At MUSC, we were not intubate at all. So then it had to be, the ER team has to intubate. But first they have to move to negative pressure room. And then once they're intubated in the negative pressure room, we have to wait a few minutes for the room to clear. Then they have to be transported. So all that time really starts adding up very quickly.
Yeah, I think across the board, and looking at both the STAR data, but also data from China, from Hong Kong, and from other centers outside of STAR and ERG, pretty much all centers saw some delay in thrombectomy protocols. And that was just due to patient screening, going to other rooms, evaluation, things that were added on top. Some centers threw in CT of the chest and specialty consults. And then on top of that, you had sort of conflicting guidelines from some of the neurointerventional groups. So some centers were saying, or some guidelines were saying you should have a really low suspicion for intubation early on, versus other centers which said we should try and conserve ventilation resources. So there was some conflict as far as should we be intubating or should we not? Mm-hmm. But I think everybody saw some delay, but then on top of that, if you moved towards a secondary change in your protocol, meaning you started intubating everybody or you stopped intubating everybody, I don't know that there were any centers that did that, you probably saw an additional wave of delays as well.
Yeah, I think so. I think every service that we interface with, and we got the ED, anesthesia, neurology, everybody has a different COVID protocol, and everybody had conflicting interests. I think that really added to the time. So Bobby, how did you guys handle it in Miami? Because you were intubate, for thrombectomy. So what was the additional layers that you saw?
Yeah, so taking a step back, probably about 2 years ago, we changed our protocol where all thrombectomy patients started getting intubated. And I think the data on whether or not you should or should not be intubating is fairly unclear. We were trying to move towards, hopefully, an international trial to compare thrombectomy outcomes in those that received intubation that those did not. So starting about 2 years ago, everybody started to get intubated in an effort to roll out this national randomized clinical trial. So we didn't change that during the COVID era. Mm-hmm. The main changes for us is we started intubating in a side room. Mm-hmm. So anesthesia would come, intubate the patient. We would hook them up to the machine, put a mask on the patient, and then transport them into the room. Okay. And some of that certainly added some delay with needing to transfer the patient and work that out perfectly. And it sounds like at MUSC, you guys started intubating just about everybody. Is that right?
We did initially, and you're right. The recommendations, if you're reading very carefully, they were very appropriate. They said, consider having a lower threshold for intubation. I think a lot of people misinterpreted that, honestly, and they read that as intubate all, which is not what recommendations from a couple of different societies had put forth. But I think at the beginning, it's a complex situation where it's really unprecedented times. We're hearing from our colleagues in Seattle first, in New York, and the conditions there were horrendous. I really think we all thought that we were going to see those same conditions, which are really pretty frightening and pretty daunting. So I think everybody did the right things and, err on the side of caution. So take every appropriate step. And we sort of approached it was a little bit of a prisoner's dilemma, psychologically speaking, because if you can get a patient through a thrombectomy awake, then you're not generating any aerosols. By the way, aerosol generating, it's language that we use now that we never even used before, and that was out of the Seattle group. But if you can get someone through a thrombectomy without them coughing, gagging, vomiting, or moving to the point you have to intubate, that definitely is the safest. The problem is that patient that then becomes agitated, vomiting, or that has to be an unplanned intubation, and that is the highest risk to everybody. So it became a really fascinating dilemma where to avoid the most high-risk setting, also you were avoiding the safest situation. And of course, we were asking our ER doctors to intubate. So at MUSC, we said, okay, look, if someone has a high NIH, left-sided stroke, aphasic, and unlikely to, or more likely to be agitated, require intubation, facial weakness, etc. When they lay flat, they're going to be not able to manage their secretions, basal occlusions. Those we consider to be high risk for converting, an otherwise non-aerosol generating procedure to one that generates aerosols by vomiting, coughing, and needing to be intubated in our positive pressure room. So those we intubated, which is honestly the majority of those that we were treating because we were more selective. And we were, by the way, a little bit more selective. To hear from both of you, we treated less, very, very elderly patients, and we were a little bit more selective of who we even brought into MUSC. So we were intubating many, many more. And we were intubating in the ER if the ER had a negative pressure room. If they didn't have one, they'd come upstairs and they'd be intubated in our positive pressure room. Then we had to wait a certain amount of minutes for the room to clear. So we definitely were seeing that 30-minute delay. But again, I think in the beginning, nobody knew what to expect. Taking all the extra precautions is definitely the safest thing for the providers. If we're not there the next day, who's going to take care of the next set of patients? And that's why I think it was so important to be able to get the data, because now I think you can monitor your situation. If you don't have that COVID problem, you could contemplate changing your protocol, like we were talking offline, to what you do ordinarily, whether you intubate or not. It's what you do routinely that you do very quickly. So I think that's the value of the data. It allows you to really look at your situation and gives you some confidence that you're not putting your providers at risk, and that patients may actually be better. But that, of course, is the crux of the data and the discussion.
There's so many dimensions to this, and you just mentioned several of them. There's patient selectivity, and we didn't know what the right posture was before the COVID crisis, right? I suspect that the same patient with the same stroke in some of our communities would get a thrombectomy and in other communities would not, or even in some communities, depending on which hospital they go to. I happen to know, you guys are probably pretty aggressive. I think we're pretty aggressive. Sometimes you'll talk to people who really, their strike zone is very small. They're really only swinging when it's right there. I don't think we formally changed our selection criteria, but I'm not sure that it didn't have a psychological effect when you looked at patients who had a poor prognosis for recovery, up front. But I think that's a moving target anyway. And then there's this issue of intubation. We have gone with strictly following the guidelines. And we're still doing the majority of our thrombectomies in patients that aren't intubated, strictly following the guidelines. I even before the COVID crisis, think I would make the argument that for a basilar occlusion or somebody who's combative and an NIH of 25, aphasic, at least in my shop, the risk benefit tips over onto the side of having their airways secured. With COVID, it's way tipped over. My interpretation, Bobby, you said the data are inconclusive. My interpretation is that if you have a center where you have really good neuroanesthesia that's there all the time and can move incredibly quickly and not lower blood pressure, probably intubation is a reasonable thing. In practical terms, though, that is not the center that most of us report to every day. Certainly not the one I report to. So I think all of that is set within the context of, as you said, Alex, we all worried we were going to be New York or Philly, next week. And it does appear that population density, together with, now a lot of the population in high hit and low hit areas are social distancing, are masking, are being more careful. It doesn't look like Memphis or Charleston or Miami is going to turn into New York or Philly, next week. We'll have to see. But the last thing I wanted to mention that no one's talked about yet is the data out of Sinai and the NYU Jefferson paper, which I've seen a manuscript on thanks to Pascal, showing a much higher risk of thrombogenicity in some COVID patients, which I also think is real. It's just that we haven't seen high numbers of COVID positive patients in our communities yet. So I think when you take all of those axes, the multidimensional axes, into account, we have to be flexible and try to avoid either underreacting or overreacting, right?
Yeah, exactly. I think that's the pendulum sort of swinging where the data kind of helps you. But yeah, based on these results, we'll intubate, like I said, the basal occlusion, those that we really think are extremely high risk of generating aerosols during the procedure. But we reverted back to essentially our usual protocol that we're very fast and efficient with, which is not intubated, and we're sort of back to those, door to groin times that we'd expect. And I was really struck when we were reviewing the data with all our collaborators. A lot of our collaborators who are low burden areas like Charleston, I think they had the same frustration, like, look, we've been doing this, we're intubating more, but we feel like there's a delay. We sort of have a gestalt that we potentially, could be a deleterious effect on outcomes. So I think a lot of the collaborators say, look, let's be less stringent. And if you think about it, it's really a testament to physicians and providers. Our nurses and techs, I reviewed the data with our nurses and techs because, we talked about making the protocol change. I wanted to be fully engaged and understand what the thought process and the rationale was behind it. So they're aware of the guidelines at the beginning of the pandemic. We're aware of what we're doing these changes. They hated the delays just as much as we do, because they want to help patients. So these are amazing people to work with, not just the physicians. But I showed this data to them last week, when it was hot off the press putting the paper together. And they were like, this is great. In Charleston, we can skip these 30, 40-minute delays and our patients do better. And they have that sort of feeling just from having, lived through the 2 months. But I think that really says a lot. There's definitely people that would say, I'm going to wear standard or extra layer PPE and presume everybody COVID positive, even if it's 1 of a million. It's not worth that risk to me. But I was really struck with how altruistic people were in taking on maybe some very, very small risk in certain areas, but for the benefit of the patients. I was really struck by that.
Yeah, and the other aspect of this, which we haven't touched on directly, is, whether you look at Akash Kansangra and Greg Alber's letter in New England Journal of Medicine or the Viz.AI data or the Get With the Guidelines data, it's intriguing that uniformly, whether it's a high COVID penetrance area or a low COVID, we're seeing drops during this period in about 30 to 35% in patients referred for mechanical thrombectomy and massive increases in last known well time. So that has nothing to do with the neurointerventional intubation protocol. It looks like it has everything to do with, maybe two putative explanations. One is it may be that patients are afraid to come to the hospital because they're afraid to get COVID. And then the second is if we're socially distanced, we may not be checking on each other enough. So there's this horrible image I have of an older patient with a stroke who's alone where, previously they would have had family around them. And that probably is causing much greater morbidity and mortality, globally and nationally than any posture we may take in terms of selectivity or intubating patients or whatnot. We really do need to make sure that patients know if they have symptoms, they have to call 911, they have to come to the hospital, and we can keep them safe.
Mm-hmm.
Yeah, I would agree with that completely. I think that was one of the strongest things I took away from this data, and also reviewing some of the other papers, like you said, from the New England Journal study and a number of the other studies which showed, ER visits across the board went down tremendously. I had patients with ruptured aneurysms, ruptured fistulas, bleeds. Of course, many of my colleagues had a lot of patients with brain tumors, all these other things. And they were afraid to either come to the hospital or the clinic or any of the above. And on top of that, the cardiologists have written a number of articles talking about delays in treatments for heart attack as well. So I think one of the most important things is once you're in the hospital, the rates of getting COVID are fairly low from other patients as long as you're segregated. So those patients are probably at a higher risk if they don't come in or don't call 911.
Well, and there is a real difference, and Alex shows this in his presentation, between, being in Queens, right, or Milan, in the peak of things. I had a colleague in Milan tell me that they were sending, ruptured aneurysms home because they simply had no room for anything but COVID patients, during the period when it was at its worst. And certainly our colleagues in New York, particularly in Queens, what they went through was really bad. I just don't know that, knock on wood, hopefully any of us, in any of our communities are going to see that. Now, who knows? Maybe this fall there will be a surge. Maybe the loosening of restrictions will result in our facilities being swamped. But my hope would be that, having seen what we've seen in these communities, we're going to avoid that long enough that we'll end up getting a vaccine. But I think that had something to do with it. We heard these stories, right? So then people were terrified to come to the hospital. But most of our community still has plenty. Most of our communities still have plenty of capacity to care for both COVID and non-COVID patients safely.
Yeah, I think exactly right. And Clement Shermer has that energy-supported collaboration manuscript that will be out in the GNIS very soon, showing that during that 2-month period of the COVID pandemic compared to the prior 2 months, I think it was 2 hours and 20-minute delay between symptom onset and arrival to the ED. For those
crazy,
reasons,
right?
2 hours and 20 minutes. It was wild. And, our stroke neurologists, they cover 50 some odd hospitals throughout the state. And the day that the governor said, stay at home, shelter, the day that was declared, 50% drop sustained for weeks. And we went out, and I know you guys have seen you guys on social media. We went out and did a video just with my iPhone edited. And I had a couple, stroke neurologists, me, were saying, look, Charleston's not hard hit. We have beds. We're half empty. We're not what you're seeing on the news, the worst case scenario. And that was about 2 or 3 weeks into it, and we just started to see a rise. But it took about a month for that misconception. And I would see my neighbors and be like, hey, Alex, how are you doing? How's things at the hospital? I said, we're fine. We have 8 admissions. We're half empty. We actually need more. I think the misperception was so drastic. So really, I think it's so important for us to be highlighting like we're doing here, that the majority of hospitals are in really good shape to take care of you. Like you said, I think, Adam, you said it best, we can take care of you safely. So you don't have to worry about coming in, So I think that's a really important part of what SNIS can help with, and all of us in our communities can help with.
Yeah, I had an anesthesiologist call me last week and say that his wife had a severe aphasia, and he'd called it his internist who said to go to the ER. He'd called a neurologist who said to go to the ER, but he was calling me because he really didn't want to bring her to the ER and have her potentially be exposed to COVID. Luckily, it wasn't a stroke, but I think the perception is clear. We've got a question about somebody who was a little late asking, were the data subgrouped into any format capturing reocclusions post-recanalization in this cohort? And I think that's from Dave Ferrara. I don't think the issue here is likely to be post-recanalization, given that we're seeing it in very low COVID positivity areas. But Alex, did you look for that, to look for reocclusion as a possible mitigating factor?
Great question. So that's not one of the normal data points of that collaboration. It would have shown up as a separate. Those are reocclusion prompting a second procedure that would have shown up as a repeat, encounter of that patient. So I can tell you, I think indirectly we did not see that, but it wasn't something we looked at specifically. But we definitely were not hearing anecdotally or in the comments as data was coming in that we were seeing any high rates of reocclusion. I think back to Adam's point about what the Sinai group found in Philadelphia, obviously much different population than what we're seeing. Younger patients with these hard clots to open. Our study wasn't really designed well to be able to answer that question, but we did see among those patients that were confirmed COVID-19 positive, they were a fair bit younger than the other patients and had higher in age. But in our data set, the recanalization success, the number of passes, the degree of recanalization, TK2B or greater, and the outcomes were the same between those two patients. But like I showed, the majority of our sites in the STAR and Energy Joint Collaboration were outside of the hot zones. So it was limited. I think the biggest takeaways are the data from the low COVID prevalent regions, because for that we have pretty robust data from 24 sites or so and, greater than 400 patients. So I think we'll have to get more information or more answers from our New York, Philadelphia colleagues about the COVID patients and the unique factors or relating to those patients.
And related to that, I've got another question here. Given the delays, have the delays resulted in us favoring a particular thrombectomy device or methodology? Given the fact that they've been a little delayed in this COVID era, I would say no. We're still favoring the devices we use, which is a fairly diverse group in my center. What about you guys? Have you during this period gone to any particular technique or technology over others?
Go ahead, Bobby.
Yeah, I don't think, like your center, we use a diverse number of techniques and technologies, and I don't think it's changed very much. I had heard from some of the high COVID population centers that the clots were more difficult to get out and were more dense, and maybe they were thinking about more commonly using a more multi-modality approach like Solumbra or something along those lines. But you're sort of mixing that with the fact that a lot of the COVID patients are younger and have straighter and easier anatomy. So I thought it was really interesting from the STAR group that the procedure times in the COVID patients were actually shorter. The revascularization rates and the outcomes were actually pretty similar in the COVID and the non-COVID patients. But potentially we need to see a much larger population to flush out some of those differences.
I know that the NYU Jefferson manuscript, which isn't published yet, does show that although the patients are younger, the cases are taking longer and are more difficult. And anecdotally, I've heard of clots forming, on stent retrievers during retraction, real frightening signs of prothrombogenicity in a younger shifted, more severe stroke shifted cohort. Anecdotally, the only thing I've heard of is not a difference in device, but a more aggressive posture in terms of using anticoagulation in general for the severely COVID positive patients. But of course, in an elvo with a reperfusion, that has its own risks. Have you guys come to any conclusions on that? Are you changing what you're doing? Let's say you finish this webinar and you got a known COVID positive 40-year-old with an M1 occlusion. Are you going to keep them on heparin during and post procedurally? How would you manage that, Alex?
So great question. So I think one is we just don't really know. I think New York, Philadelphia, they certainly saw a different set of patients, and their setting is entirely different than my practice. So we're relying on them getting us more and more data as they treat more patients. I think certainly the STAR and energy data doesn't really help us answer that. I think from my standpoint, I wouldn't necessarily change anything at this point. I think it's just too early to tell. There's just too many question marks. We just don't have the robust enough data to really recommend that. What we are going to do, we're going to start from the STAR database. What we really have is a nice repository banked data. So for example, we can compare, say Memphis, if you had been a hot zone, we could have compared your 2-month experience of the pandemic. You were a cool zone, but had you been a hot zone to your previous 3 or 4 years, we can really get a true baseline. We can really pick up signal, even a small signal. We have hundreds of patients as a baseline. So the next step is, of those 28 centers that we had the data, of course, of which 80% of them were in cool areas, we're going to start focusing really carefully in those 6 or 7 sites for which we have a lot of baseline data, and really start to look at very closely. Were we treating different patients? Well, part of it was selection bias, not treating older patients. Were we seeing different patients? Were they behaving differently, like you said? More stubborn clots requiring longer procedure times and more maneuvers. But I think as of yet, for me, it's still unanswered. It's definitely fascinating, what we're hearing from New York and Philadelphia. I think we definitely need to keep looking, but for me, it's still unanswered. But Bobby, what are your thoughts?
I mean, all great points. There was a good publication in Journal of Cardiology showing that patients that were getting heparin in the setting of COVID had better outcomes. Now, of course, you have a selection bias. Those patients were probably more likely to have certain parameters that made them less healthy. I think the paper from Columbia and NYU and a couple of the other papers that just came out this week showed that most of these patients that were having strokes and COVID had coagulation alterations. So D-dimer levels were elevated, ESR was elevated. There are alterations in PT, PTT, INR, all of those things. I think you have some risk when you revascularize somebody on heparin. Potentially, they're at higher risk of having a bleed. In the STAR database, it wasn't significant, but there were a higher number of bleeds in COVID patients. So 15 patients in the COVID group, 15% of patients in the COVID group had a symptomatic hemorrhage versus 5% in the non-COVID group. So that wasn't statistically significant, but it's a threefold increase in symptomatic hemorrhage in the COVID patients. So the question is, if you added on heparin, are they even more likely to have a bleed or a worse outcome? All of that's really unclear, but generally speaking, if they didn't have a bleed, you probably would want patients on heparin, and they probably do have a better chance of having a good outcome. So for me, I probably would do the revascularization, get a CT scan afterwards. If they didn't have a bleed, I might consider heparin if their coagulation parameters were really off.
And let me riff off of that for a minute. So there's been this discussion about whether the cytokine storm could create an inflammatory endothelial type situation. I don't know, but I certainly think it's possible that somebody who is hypoxic and potentially septic from a viral pneumonia for a week before they finally present with a stroke could have, severely impaired coagulation. Now in our previous exposure to these patients, right, the severely ill pneumonia patients who come in with stroke, they are prone both to coagulation and to bleeding events. And that's a point that you make, Bobby, I think is very true. So I'm a minimalist. If the intensivist says that he wants the patient or she wants the patient on anticoagulation and this is incidental to a thrombectomy, that's fine. But as a proceduralist, if you're able to get a TICI-3 result, I don't know that positivity alone would lead me to change my protocol. I would probably say, well, look, there's a higher risk of it recoagulating, rethrombosing, yes. But we'll just have to cross that bridge when we come to it. It'd be interesting to ask some of these high COVID areas if they have a different opinion on that. But in the absence of true data that says we should do something differently, I'm gonna stick to being minimalist.
I think back to the question of the younger patients or not. It's tricky because there's so many. You alluded to before. This visual of the little lady at home having a stroke and nobody's there to pick it up or take her in, and we know that fear was keeping patients with chest pain at home. I mean, a stroke is bad enough, but you're talking about people with chest pain. So I think we just have to be mindful. I think if it would make sense that it would be a younger population overall will be presenting during the COVID pandemic because they're less susceptible, they're less vulnerable, they're probably less, I think there'd be more reluctance to bring in a really elderly person, and we were more selective in treating less elderly. So I think that alone could select for younger patients. So I think it's really tricky. There's so many, there may very well be something to it. It's just so hard to tell at this point. And to your point about, the really sick patients, the inflammatory response, et cetera. But asymptomatic patient, by being asymptomatic, you wouldn't expect them to have the inflammatory response because they wouldn't have any of the symptoms, fever, et cetera. So these are really tough questions that we just don't know.
So we've got a couple other questions here. This is one that I think a lot of people have thought about. Given the higher risk of thrombogenicity and the fact that COVID infection rates are going up, in an elective patient treated with a flow diverter, should we consider a longer period of dual antiplatelet therapy, or is it too early to tell? I know there's a lot of concern, whether we should continue to enroll in trials, whether we should change what we're doing for elective aneurysms in light of the COVID pandemic. Do you guys have thoughts on that? Bobby, I'll start with you.
Yeah, that's a tough one. I mean, I don't think that we have long-term data to support altering our regimens. We have quite a few trials going, and we have had quite a few meetings about whether or not we should alter enrollment. For most of those studies, they were delayed or put on hold. More recently, we've started to go back to doing those cases again because, generally speaking, our case numbers for COVID-positive patients are so low. But we certainly had a period where we were delaying elective cases, and we were also delaying the start of a number of major trials because of concerns for increased thrombogenicity. At this point, a number of those trials have gone ahead, and so far it seems like the numbers are extremely, extremely low. But I think that is a reasonable concern. So for us, we haven't changed our protocol so far.
Yeah, I think, Adam, I'm like you, a minimalist. So to me, in the absence of really convincing data, I'm going to stick to with what I know is safe and what's worked in the past. And I just haven't seen that. Certainly in our community, it wouldn't make sense because we're such a low prevalence. So I think for us, it just wouldn't make sense. In other regions, you may have to tailor it to your region. But for me, with an absence of really, really strong data, I sort of hesitate to change our protocols that we know are tried and true.
Certainly,
Yeah,
for a lot of the really large trials, we delayed them. And then on top of that, we also built in more frequent review of the data and also checks. So anybody that has a complication, we built in the fact that they're going to be extra scrutinized. They're going to be often tested for COVID and things like that to make sure that we're not increasing the risk for our patients.
Yeah, I mean, I think clinical research is really built on our clinical standard of care. And so at my hospital now, everyone's tested for COVID within 48 hours of initiating an elective procedure anyway. And so any research on an unruptured aneurysm is going to be built, on that stratum. And so I would hope that given that in all of our research studies, we're checking for concurrent conditions, we're checking for adverse events, that we can still do this responsibly and with good results for patients. I already was leaving somebody on dual antiplatelets longer if they had a long flow diverting construct, or maybe multiple stents. In the horrible case of somebody with a ruptured blister aneurysm or something like that. So I was already modifying it a little bit, but I don't think I would keep somebody longer if they were COVID positive. Like I said, I'd want to know what the pulmonologist, what the intensivist wanted more in general terms than, thinking specifically about a flow diverter.
Adam, you mentioned about testing, so it's sort of unrelated but related. Is we were really hoping as we were changing our protocols for the intubation or not for thrombectomy, had we been able to get this really, really rapid, not the hour, but the 50-minute rapid test, it would have solved our problems, especially for the 65% of strokes which are after hours when we're driving in. But of course, we never got it because we didn't need it in New York, and other hospitals needed it, which I think is sort of an interesting by itself. But I wanted to ask you, you alluded to the fact that the outpatients you're testing, are you guys now at your centers testing the inpatients? What's the protocol? You're testing your providers? What are you guys doing?
Yeah, all of this is a moving target, but we have already begun testing providers, and that's going to ramp up. I've been tested twice. It's not a particularly fun experience. All outpatients coming in are tested, and we're starting to test all inpatients too. So I think as we get better, and that's the other thing, you feel comfortable knowing that there's a test, but we had a patient here in the ICU who clearly had COVID. I mean, his lungs looked terrible. 3 tests negative in a row before the 4th one turned positive, and he hadn't been exposed to anything new in that time. These tests aren't perfect. And the antibody test isn't going to be the holy grail either. That's not perfect either. So, we're going to have to continue to use our best judgment in terms of how to treat patients with testing as only a part of the overall fabric.
Mm-hmm.
I think that's another extremely important point. So we're testing now 48 hours in advance for all elective cases as well. I've had multiple patients that tested positive and negative, or negative then positive. We test them again at 2 weeks. One is positive, one is negative. And it kind of depends on the test. So for the STAR data, it was supposed to be PCR testing, but it also then depends on which of those tests. So you have the greatest test for stroke is the rapid test, which takes about 15, 20 minutes. So then you would potentially get those results back as the patient is getting to the angio suite, or certainly have the results back so that you could triage where to send the patient after the thrombectomy was done. Then you have the next set of tests, which take about 2 hours or so, the swabs. Mm-hmm. And my understanding is those have about a 70% sensitivity. And then you have the next set of tests, which take about 6 to 8 hours, or at least at our center, which are the multi-length PCR tests, which I think have about a 95% sensitivity. So we were also just sort of struggling with which is the best test for stroke patients and also just general patients. But if you use the most sensitive test, it's not back by the time you're done with the thrombectomy, and then it's a little bit harder to triage the patients. But right now, we're testing everybody within 48 hours of an elective case, at least.
You know, it's easy to see this as so much uncertainty, but we're so much better off now with what we know about transmission, what we know about the disease, than we were even a month or two ago. Between social distancing, mask wearing, testing, the infection rates are just dropping dramatically. It's amazing to see what a country like Japan has done in terms of just a couple hundred cases. So, you know, I think we can take care of stroke patients despite, you know, this factor, this twist. We just have to figure out, you know, what to do in which case, which, you know, we already didn't know everything. So, well, any closing thoughts, Alex or Bobby, on these data, or how to advise our colleagues who are taking care of stroke patients during this time?
Sure. I'll take the first stab, Bobby. So I think, you know, kind of taking the 50,000-foot view, I think it's important, you know, we're 2 months in, like you mentioned, Adam. We know a lot more than we knew a month ago and 2 months ago. And I think some of the STAR and energy data really kind of helps us, in particular in the low COVID burden regions. Probably not so helpful in the high COVID. We just didn't have enough sites represented. But we had 20 some odd low COVID burden regions, so I think that was a fairly accurate representation. I think there we really, it's a 1% of mechanical thrombectomy patients end up being positive, so it's fairly uncommon. And like I mentioned, 19 of the 23 sites never saw one in the 2-month period. And anecdotally, and the data showed, there were definitely delays, like Bobby mentioned, beyond just putting the tube in the trachea. Was transporting, was the ER versus anesthesia, was changing your protocols. Negative pressure room versus positive pressure room, clearing the air in the room, et cetera, et cetera. So there are definitely delays. I think everybody can probably look at the data and say, let's assess our situation. What's the level of the threat to us, our providers? If it's very, very low, I think they can discuss a group like we did, and they could perhaps relax some of their criteria and go back to what's try and true for their center that works very efficiently, like we did. And I think that, you know, showing that, like we did, the prevalence of COVID-19 patients in the low COVID burden regions was very low, and zero across all those sites, 0 providers became COVID infected. I think that can give you some reassurance you can scale back. I think without that data, it's really hard to scale back. And there is a suggestion based on our data that the delays really do matter for these patients. But it's not just a trivial that the outcomes could suffer. But in the end, it's a really fascinating topic because it comes down to balancing act between patient outcomes and provider safety. And we usually don't have to think about it in this way. So I think it's really important that we keep thinking about it, getting more data, and keep discussing it like we're doing now.
Bobby?
Yeah, I think all of those great points. You know, I think certainly some of the key takeaway messages are symptomatic patients should really be coming into the ER for evaluation, especially if they're outside the usual situation. So that may be younger patients. Other than that, we need to keep collecting the data to look forward at the outcomes. I mean, I think that was one of the limitations of our analysis. Is this is really an acute period analysis, but we don't have functional longer term outcomes as to, you know, how these patients are really going to do. I think those were kind of the key thoughts from my side.
Yeah, we had a couple of questions come in. One here is, has the incidence, clinical presentation, or outcomes in ischemic stroke experienced any changes in the coexistence with COVID-19? Well, yeah. So we know that for stroke in patients with COVID-19, the cases are more difficult, the patients are younger, and the outcomes are worse. And then based on the data that Alex led the study on here, we're actually seeing changes that are related to our health system's attempt to deal with the COVID crisis independent of COVID-19. And then, you know, lastly, there's the impact of the social distancing and social anxiety related to healthcare that we discussed, which may be the greatest impact of all, right? The greatest impact may not be the thrombogenicity of a COVID patient, nor the effect on our healthcare systems, but the effect on society and getting patients in. And in regard to that, as was mentioned earlier, our colleague, Dr. Clemens Shermer from Geisinger, has led a paper that will be published in JNIS. And so next Thursday, on June the 4th, is going to be the first JNIS Journal Club. And actually, that's what they're going to be discussing, is the data showing a tremendous increase in time from last known well and a decrease in the number of stroke patients we're seeing. So there are those multiple dimensions. I'm really grateful that this study looked at how it's impacted our ability to care for the patients, but then there's also the impact of the disease on stroke, which is intriguing, and the biggest impact of all, the impact on society and our systems of stroke care, so that these patients can actually get the care they need. So with that, we're right at about an hour. I think we answered all the questions. I'd like to thank Professor Spiota and Stark both for their willingness to come and discuss this situation. I'd really like to thank Penumbra for sponsoring this webinar, a company that has supported our ability to care for stroke patients before, during, and presumably after we get through talking about COVID. And thank you to the 250 to 300 audience members that tuned in to ask questions and hear about this.
Thanks so much, everybody.
Thank you. See you guys.
Thanks, Adam. Thanks, Bobby.
Yeah, thanks very much.